To all four of you, thanks for your important work in this field. As you know, the Senate has been grappling with this. We spent 2.5 weeks on the floor on this legislation called the Comprehensive Addiction and Recovery Act. We spent 3 years putting it together. We had 5 conferences here in Washington. Some of you participated in those. We brought in experts in various areas to try to figure out how to get at the very issues you're talking about, dealing with this not as a drug problem, but as a public health problem, acknowledging that this is an illness, this is to be treated as a disease, trying to take away the stigma, which Chief Ryan, you've talked about, which I agree with you is part of the reason people are not seeking treatment. There are other reasons as well. I'm someone who is frustrated because I've been at this a long time. 22 years ago, a constituent came to me when I was in the House and said, my son just died, what are you going to do about it? And I was fully armed with all the statistics on, $15 billion a year on interdiction and eradication of drugs and on prosecution and incarceration. And she said, what are you doing for me in my neighborhood? And that led to a whole series of thinking and frankly, to a different position on my part in terms of focusing more on the demand side. And we did pass a number of bills, Drug-Free Workplace Acts, Drug-Free Media Campaign, which I was proud to be the author of, but also the Drug-Free Communities Act. We sent out $1.3 billion, spawning 2,000 community coalitions around our country, including one I chaired in my hometown for 9 years, and I was on the board of before I ran for this job. Still very involved with it. And I think CARA addresses much of what you're talking about. It won't solve the problem. This is, Washington is not going to solve this problem. But it does focus on primarily 4 things. One is the notion of much more emphasis on prevention and education. And David, you talked a little about that, and the importance of not taking your eye off the ball. And I think that's one of the problems we've had is we go up and down. When we solve a problem, we had cocaine solved, you recall, back in the 80s. And, thanks to a basketball player at University of Maryland, everybody thought cocaine is the issue. We're going to focus on this. When Bias died, there was a lot of emphasis and focus. As soon as you take your eye off the ball, it's something else. You mentioned methamphetamines here today. You mentioned cocaine coming back. I would tell you overdoses in my home state of Ohio. We're starting to see more cocaine. We're starting to see more meth coming back, and we thought we'd sort of turned the corner there. So every time you take your eye off the ball, I agree with what was said here today. Something will crop back up again. So I think there's a growing consensus around this issue of treating it like a disease, addiction, removing the stigma so people get treatment, focusing more on demand rather than just focusing on the supply side. And by the way, you look at where the money has gone. Drug-Free Communities Act is part of this, but there's been more money placed on the demand side. I would say still not enough, because I think this will, unfortunately, it's not going to be solved at the border. If it's not, in my view, and I'm not necessarily speaking for my colleagues here on either side of the aisle, but we're not going to be able to solve this problem by building a bigger wall or by stopping it at the border, because methamphetamines can be made in the basement. By the way, so can fentanyl. And fentanyl is a synthetic form of heroin that can be made by a chemist, and is. So I have 3 questions for you. One is with regard to medication-assisted treatment. It sounds like, Dr. McDonald, that you've had some success in essentially using synthetic heroin to keep people stabilized and have gone back to work. You didn't mention what your percentages are. I'd love to hear that. You did say that by dealing with the underlying psychological and mental health issues, some will step down to less intensive treatments and gradually wean themselves off, and some are back at work and back with their families, and I assume into a life where the drugs aren't everything. Can you give us some sense of what the percentage is there? And then also my question to you all is, what are some other potential medical breakthroughs here? I mean, the one that we're using in Ohio a lot, we have 12 pilots right now, is Vivitrol, and the notion is you have this blocking of the craving rather than a synthetic form of an opioid or an opioid in the case of methadone or Suboxone. What else do you see out there, and what do you think about Vivitrol or other drugs coming on? And then finally, how about pain medications? I mean, 4 of the 5 heroin addicts in Ohio started on prescription drugs. And prescription drugs, as was said by all of you, it's a legal prescribed drug. I couldn't agree more with what David Murray said about the perception of harm. All the evidence shows this. If you show there's a perception of harm, you will have fewer, particularly young people, getting into this. But what's the perception of harm when a doctor gives you, 80 Percocets when you get your wisdom teeth taken out? And I know 2 parents back home, 2 parents who lost their child because a child went in as a teenager to get their wisdom teeth taken out and ended up getting addicted to prescription drugs and then moved to heroin and overdosed. So how about pain medication? When was the last time there was a new pain medication to come on the market? You know, why are we using prescription narcotic drugs to deal with things like an extraction of a wisdom tooth or even a sports injury, when there's got to be much more targeted ways in which to deal with that pain and pain management? So those are the questions I have, and open up to everybody.
So we've only had a treatment program in Vancouver for about 2 years, so it's early days. We're still learning and still studying our patients. Our patients that are working or found work are a small number. It's probably about 5%. That's still significant and hopefully will grow. The other side of that equation is our patients have been using illicit heroin for 15 years on average and longer. Ideally, I'd like to engage those folks earlier, not wait 15 years before we intensify their treatment. With regard to pain medications, I think there is overuse of opioids for pain medication, and that needs to be reduced. But when it comes to people with severe opioid use disorder that need access to care, need to increase access to opioids and treatment for them. So there's two sides to that solution.
If I could just add to that, Senator Portman, and I just want to thank you for your leadership on CARA. I think that there's many elements in there, especially expanding access to methadone, buprenorphine, making naloxone easier to get, opening up the possibility for funding more diversion programs by law enforcement that are really wonderful elements and really important part of the solution to this. Let me